I'm really excited to be here as a trainee presenter for you all today, and I'm really proud to present an Australian trial. As you can probably tell from my accent, that is where I hail from. So we will be discussing the recent publication from Dr. Dargaville, who's here today, the 2-year outcomes after minimally invasive surfactant therapy in preterm infants, the follow-up of the Optimist-A randomized clinical trial. So today I thought it would be great if we looked at the background and sort of talked about what exactly was involved in the first Optimist trial, just remind ourselves of what that was, and then really dive with the help of our moderators into understanding the Optimist-A2 follow-up trial. And then I thought if we had time, it would be interesting just to sort of chat about the importance of important follow-ups in neonatal trials and some of the difficulties and challenges that do come with this. For today, I know that we're coming from different parts of the world. I just wanted to start with some definitions to sort of reduce any confusion. MIST and LISA are the same thing. So in Australia, we tend to use the word or the shortened term MIST for minimally invasive less surfactant therapy, but I've noticed over here and in Europe, the term LISA or less invasive surfactant therapy tends to be used. And this is surfactant administered through a small catheter and laryngoscopy without intubation with an endotracheal tube. So this is not to be confused with INSURE, which is the method of intubation with an ETT for the purpose of surfactant administration. And then I hope this is working, but I do know that, sometimes we're not all even practicing with a MIST or a LISA approach. So I wonder if this will work, and if you have a QR code, we can just get an idea of who in the session today has used MIST, is familiar with MIST, might not have seen MIST in their unit, or have maybe only ever heard of it. I wonder if that's working. Okay, cool. Got some, okay. Bit of even spread. That's good. Got one unit that routinely uses, two. Okay. I think there are about 30 people in our session today, so I might just wait and see if we get a few more answers. Okay. I wonder if our moderators are surprised by this or not, or if this is what they would expect to see.
Peter Dargaville here. So I imagine this is a North American audience, probably an audience purely from USA, and this is pretty much what I would have expected. There's what I know from my visit to the US, to conferences and to centres, is there's a very broad current approach where some units have been, let's call them early adopters, and yet others are still considering the position, which would be a good point of discussion today.
Yes.
Somewhere around 15. Somewhere around 15% of the units are starting to adopt LISA in the US.
Nice. And I've got another little poll for everyone, so might need to get our phones back. And for those of us who are familiar with MIST and who do use MIST on a sort of routine or somewhat routine basis, I'm just wondering what sort of babies you are using this practice for. Which infants are your units misting? Are you happy to try minimally invasive surfactant on any infant, slightly bigger infants, or term infants, or if you don't mist at all but wanted to vote, I put in an option there. Okay, that's good. Okay, great. Okay, great. Very good. And for those of us who might be familiar with actual procedure of MIS, video, which I believe is Dr. Dargaville's team. Hopefully it works to sort of show and refresh how we would expect them.
Here, resuscitation mannequin, equivalent to 27-week gestation, 1 kilogram preterm infant. Narrow bore semi-rigid catheter is divided into the trachea without the need of forceps. This catheter is inserted through the vocal cords of the desired depth by direct or video laryngoscopy. The catheter is there pinch held at the lip, and exogenous surfactant is delivered at least 3 aliquots, with a 10-second pause between each. Surfactant dispersal from the trachea is driven by the infant's spontaneous breathing, which is remote by tactile stimulation and supported with uninterrupted application of CPAP. Entire surfactant and CPAP continues. Improvement in oxygen requirement and breathing mechanics would be expected after the procedure.
So that's just a little quick familiarization with the attention to the fact that the non-invasive ventilation support that the baby is receiving is kept on the entire time of the procedure. And that's really important.
Hey, Anna, can you turn off your video? Your connection is pretty unstable.
Oh, sure. Okay, sorry.
Yeah,
hopefully this improves things. This improves things. So I did think it was really important. Great, thank you. I did think it was really important today that if we're discussing a follow-up trial, we should also sort of have the original trial in the back of our minds at the time. So if anyone doesn't have the trials pulled up or they'd like to read them, these are the 2 trials that we will be discussing sort of today, with our main focus being on the follow-up. So the first trial, the trial that sort of started it all, was the effect of minimally invasive surfactant therapy versus sham treatment on death or BPD in preterm infants with respiratory distress syndrome, the Optimist-A randomized clinical trial. And a little fun fact is I actually helped with one of the patients in this trial actually at the Royal Women's Hospital in Melbourne. So I'm very familiar with it. A little sort of background, respiratory distress is very, very common. I don't think you could walk through any of our neonatal units at the moment and not encounter a patient with RDS. It occurs in approximately 1% of the population. However, when we start looking at preterm babies and extremely preterm babies, the incidence does really, really, really increase. The diagnosis is made on a combination of clinical features. Tachypnea, these babies breathe fast, they breathe shallow, they have nasal flaring, grunting, retractions, they can be cyanosed, they will have an increased oxygen requirement, and of course, there are changes on the chest x-ray. The natural history is for the clinical signs to develop within 6 hours of life, and then they get worse before they get better. And you will see this in clinical practice, and the babies will sort of puff and puff, they'll sort of get worse, they'll have that nice big diuresis, and then they will hopefully improve. Treatment, temperature, we want to keep these babies really nice and warm. If they're cold, it's not going to help at all. We need to support them with some sort of ventilation, whether that be, they could be significant enough that they need invasive ventilation, or what we're talking about today, non-invasive ventilation. These babies need surfactant. Most of the time they're going to score some antibiotics. We don't want to overhandle these babies, and they're probably not appropriate to breastfeed. And RDS is a disease of surfactant deficiency. And why is this? And why do we see it more in our preterm infants? Well, this is my favorite, one of my favorite pictures ever. It's very, very clear. We get our babies in the ICU sort of around this canicular sacula, and you can see that here is when we start to develop surfactant. So a lot of these babies only have the very start of this surfactant production, if any. So we need to give them some exogenous surfactant to help support respiration. So what did Dr. Dargaville and his team wanted to do? Their population was preterm infants. So this is the first trial that the follow-up trial was based on. 25 to 28 weeks, so extremely preterm infants on CPAP with an oxygen requirement around 30% within 6 hours of birth. Their intervention was missed, so the non-invasive respiratory support with the minimally invasive surfactant via the thin catheter. Generally, it was an angiocath, I believe. Maybe Dr. Dargaville, you could correct me. The comparison was a sham intervention, so transient repositioning. So basically, we went behind, for some units, there was a curtain. We went behind it. We sort of turned the baby as if we would turn them to give them mist, and then turned them back and sort of talked through what we would do to make it sound sort of like, so that the team couldn't tell if the baby was actually getting misted or if the baby was just having a if the baby was actually having the procedure. The outcome was a composite outcome of death of physiological BPD assessed in 36 weeks post-menstrual age. And they were also looked at these outcomes individually, and it went from 2011 to 2020.
So it's a good point to turn to Dr. Dargaville and gain his insight into how we designed this trial, what was his thought process, what was the available literature at that time, and further insight into that.
Very happy to do that. I'll try and be brief. Yes, so our trial started at the beginning of that decade, at which stage there was only one other published trial called the AMB study, which is quite a similar design, but smaller numbers with only 200 babies. And so we had hoped to do what we intended to be as definitive a trial as possible, comparing giving surfactant at an early and low oxygen threshold and an early time, compared with continuing on CPAP with the notion that that was the standard treatment that was being used at that time in the wake of the intubation versus CPAP studies and the gradual uptake of CPAP. So that's what we were intending to do. And in the time from starting to finish our study, a lot of other studies got done, which largely were head-to-head comparisons of giving surfactant via a thin catheter or an endotracheal tube, largely with Insure. And so because our trial went for so long, the literature and the science was advancing all the time through the study. But we still ended up, even though we fell short, as Anna will tell you, of our intended sample size, we did end up with the largest study to date, looking at thin catheter delivery of surfactant compared with any comparator.
Dr. Ramanathan, can you give insight of what was the scenario? I think this trial took 10 years to finish. In 2010, why was there a push to have a more non-invasive way of delivering surfactant? And what was the physiology and the understanding at that time?
We know that even brief period of mechanical ventilation causes lung injury. So, and the original description by Hendrik Werder, he did a study in 1990 in Kuwait. There are no mechanical ventilators. So he gave babies on CPAP, gave surfactant, and they had no choice but to take the tube out because they can't keep back the baby. So he coined the term Insure, intubation, surfactant, and extubation. The problem in majority of the centers is the intubate, difficult procedure, give surfactant, and they don't want to extubate the baby because they may have trouble re-intubating the baby, or they think baby might need a second or a third dose. I really don't want to extubate the baby. So the Insure was not practiced as it was recommended by Dr. Werder, Professor Werder. So that was the problem. That with increasing use, understanding that even brief period of mechanical ventilation, especially during the transitional period in preterm babies, will lead to lung injury and BPD. We all know that, right? So slowly it has evolved that non-invasive ventilation, either CPAP or NIPPV, became the primary mode of support in majority of the babies, at least 26 weeks and above. That was the rationale for doing the study, and try to avoid intubation. We know that one of the reasons for surfactant therapy is CPAP fails. If in babies that are on CPAP that meet the criteria, which we'll probably discuss about it, whether 30 or 40% FiO2, if you do not give early surfactant, the CPAP failures are high. Peter Dargaville, professor, published a paper on it from Australian New Zealand network. There are 3 more studies, one from Dallas, one from Poland, third group, the Peter's study. All 3 retrospective studies showed that in babies that meet the criteria, one of the criteria that came out consistently in all these 3 reports was FiO2 of 0.29 or 0.3 in the first 2 hours of life. If you did not give surfactant, they fail CPAP. And of course, CPAP failure means intubation on all the associated complications.
That's a very good insight, and we're grateful for Dr. Dargaville to finally take this huge task of answering this question. Anna, you can proceed.
Thank you. And thank you for that insight. That, yeah, it's really important, because we do know that any time with mechanical ventilation can be injurious to a preterm lung. So this was their population flowchart, and if we just zoom into it, as Dr. Dargaville did say, I know that they did want a higher amount, but they still had 488 preterm infants randomized, and this is a huge accomplishment. It's very, very, very difficult to run a large-scale clinical trial like this, and 488 infants is just fantastic. So they had 242 in the intervention group that received minimally invasive surfactant, and 244 were in the control group. One in the intervention group was not included in the final outcome because they had their consent withdrawn, which also happens.
So,
and then if we look,
quick question for you. So the trial took 10 years. I know COVID was one of the reasons for it to terminate a little early. Can you provide why it took so long? Was there some equipoise among the participants, or any difficulties you face where we can learn from?
Yeah, that's a very good question. When we started the study, we were hoping to involve mostly units in Australia and New Zealand, and a number of them agreed to participate, but many elected not to because the therapy was rather novel and the data and the evidence was only just being accumulated. And so we had to go multinational with this study, and it ended up being conducted in 33 centres in 11 countries. And it obviously took a long time to get those centres on board. And any of you who've participated in trials or designed them will know how difficult it is to get even one centre on board a study these days. And so we were actually still having centres join the study even very close to the time when we had to stop our enrolment. And the other thing to say that did slow recruitment is that what Anna didn't show there is we screened 5,000 babies to end up with our 488. And many of them born in the participating centres got intubated soon after their birth, so they were immediately excluded. I think that was about 40% of all the possible babies that could have been involved. And then of the ones that did start on CPAP, around 50% of them didn't qualify for potential enrolment by virtue of not achieving the FiO2 of 0.3 in the first 6 hours, which was the inclusion criterion. And so this was quite a selective study. And that meant that it was hard to find babies to include. And the third thing to say is that then there had to be a treatment team available to administer the intervention, active treatment or control. And that was a showstopper for some units and for some units at various times of their day-night cycle. They wouldn't have a treatment team available. So those are important reasons why recruitment was slow. As to your question about equipoise, yes, there were some units who were involved in the study in the early years and then elected to not continue. That happened in a few instances because they felt the therapy seemed to be of benefit.
Thanks for the insight. Anna, you may proceed.
Thank you. And thank you. Yes, I probably should have highlighted again how from 5,187 babies, 488 were randomized.
My AirPods would switch over, but they didn't. No, you're good.
Ooh. So still a huge effort from the Optimist team to get their 488 babies. So let's look at their outcomes. A composite outcome means sort of either or. So you either have died at 36 weeks or you have sort of like a diagnosis of BPD, but then they also, as I said, they looked at these outcomes individually as well. And what did they find? So the composite outcome, they did not find a significant difference between the missed therapy or the control, and death, they did not find a significant difference. However, there was a significant reduction in BPD in the infants who received the surfactant therapy and the missed sort of therapy. And this is really important because it does support the physiological hypothesis that, you know, surfactant does reduce BPD. Yes, Dr. Ramanathan?
Yeah, I mean, lots of problems with the composite outcome, either death or BPD or
yes.
death or BPD. You know, we're used to that, but I think in adult medicine, it's very rarely used. You know, they use so-called win ratio. I don't think I've seen anything in hematology. There are a number of assumptions, right? The primary outcome changes in the opposite direction. Classically here, there was BPD was alone was significant, right? But composite outcome death or BPD was not significant. So that's a major problem in neonatal studies when you use the composite outcome.
Thank you. That's very, very true. And also, with any sort of clinical trial, you always have to be aware of any sort of potential risks or other sort of pre-specified clinical outcomes and safety outcomes. And here you can see that there were two variables that did have significant changes, which was pneumothorax requiring drainage and the need for intubation within 72 hours of birth. The other outcomes that were chosen, IVH of grade 3 or 4, death or major morbidity during first hospitalization, death during first hospitalization or major morbidity. These are all really standard and really important outcomes or secondary outcomes to have in neonatal research, because there are sort of most likely adverse events that these tiny babies may experience. So that's a little rundown of the first Optimist-A trial. I don't know if the moderators want to just chip in anything extra about the first trial, because now that we've got that in our minds, I'm going to move on to the actual paper that we're discussing today, which is the follow-up of this trial. So a lot of big neonatal trials now, there really needs to be an element of follow-up, because I think about this in the fact that, you know, neonatology and neonatal research is still relatively new in the scheme of medicine and medical research. And we don't have great follow-up for starters for some of our research. So it's really important now that we're always thinking when we're designing trials, when we're conducting trials or contributing to trial design, is there an element of follow-up that's coming through? Are we going to be able to look at these babies? Because it's all well and good if we do something and it has a great effect in the short term, but we have no idea how these little kids are going to end up at 2 or 5 years old. So it's really, really important that when we're thinking about interventions, especially those that happen in the first week of life or the first even 24 hours of life, it's really, really important that we still have in the back of our mind that we need to always be thinking, is there an element of follow-up that is appropriate for this trial in this cohort? Which, yes, it was, and that's what they did. So 2-year outcomes after minimally invasive surfactant therapy in preterm infants, follow-up of the Optimist-A randomized clinical trial. And this was recently published in JAMA. So congratulations. It's such a good and important article for people in the neonatal world. So we remember that the population was extremely preterm infants on CPAP requiring FiO2 of 30% or more within 6 hours of birth at 2 years of age. And 2 years is a really critical point. But I might ask Dr. Dargaville, it might be a bit of an obvious question, but I'll still ask you guys to answer. Why 2 years?
Yeah, this has been a typical age to do follow-up of preterm cohorts, but it's now increasingly acknowledged that, particularly for neurodevelopmental outcome, but also for respiratory health, even at 2, we're only just beginning to get the glimmerings of what the child's going to exhibit as they continue on in their first decade. But they're still often captive to the hospital of their birth at 2 years of age, because many follow-up programs that operate routinely operate until 2. That's how ours works, and then after that, the child's released into the world, so to speak. And so it's a convenient time, and there is, as we'll see, quite a lot of information to be gained about what happens in that first 2 years. And in the case of respiratory health, if we use metrics of vulnerability, such as hospitalizations and symptoms, they're often very prominent in the first year or 2 and become less prominent after that. So there is a rationale in relation to respiratory health for choosing the first 2 years.
Thank you. It is really important. Again, our intervention was the MIST procedure. Our comparison was the sham, and the primary outcome of interest in the follow-up was neurodevelopmental disability at 2 years corrective age, and the time was 2 years after initial enrollment. So, population. Let's have a look at which babies from the original trial were captured. So if we remember, in the original trial, the team screened nearly 5,200 infants, which is huge, and they had 486 enrolled and randomized. And then we look at follow-up. So they've randomized, they've gone out, been discharged or whatever, and then they have to be sort of caught and approached by the team to do a follow-up. So let's break this down and look at the control group. So there were 244 infants randomized in the control group, and of that, the team had 229 infants with follow-up data. 10, they had sort of incomplete data on neurodevelopmental disability. 24 infants died before the 2-year time period, and 205 survived to 2 years corrected. And they actually had 195 participants with a full neurodevelopmental assessment, which is, again, very, very, very impressive. And, oh, I've lost my intervention one. I apologize. And in the intervention group, they ended up with 186 infants who had complete follow-up data. And this makes a total of 78% follow-up, if my maths is correct. And again, the team really need to be congratulated with this, because if we get time to chat about follow-up later, it is difficult. There's a lot of phone calls, there's a lot of research teams chasing people around the country or internationally, and 78% it's a really big achievement. So well done. Yes, Dr.
Excuse me, Anna.
Peter
Dargaville.
Sorry?
The rate of follow-up I think your calculation there is based around the total number, but actually the rate of follow-up for babies who survived was higher. It was actually 89%. That was our follow-up rate for ascertainment of the primary outcome in those babies who survived to 2 years of age.
Sounds good.
Sorry, yes, you're right.
And again, the primary outcome was death or neurodevelopmental outcome, not just neurodevelopmental disability.
Thank you for that. Correct.
Yeah.
Thanks. But 89% follow-up, that's hugely, hugely impressive, and you should all be congratulated. That's really, really fantastic, because I know like when you go to meetings, someone will always ask, oh my gosh, how do we do follow-up? How do we capture these families? And how do we, you know, get them back in to do these really extensive sort of follow-ups? And it is, yeah, it's really, really difficult.
Get somebody like
Dr.
Get somebody like Dr. Dargaville to keep sending you the emails every day.
Yes.
PIs and sites.
So very true, very true. So our sort of intervention and comparator, I sort of thought this is a nice time to sort of chat about the actual study design and how the nitty-gritty of how this follow-up study was conducted. I've got my consort checklist here. Let me see if my Zoom will work. So I want you to all just be thinking about this in sort of the back of your minds when we're thinking about how to design a trial, the methods, the participants, the statistical methods that were chosen, etc., and have this sort of consort. You can just Google it and have it up while we're chatting it through, and it can be helpful to think about trial design. So hypothesis. We always need, any sort of research, you need to start with a question to be able to think about a way to get an answer. A hypothesis that application of MIST would reduce the incidence of the composite outcome of death or moderate to severe neurodevelopmental disability or its components. And that came from the original hypothesis that the administration of surfactant via a thin catheter would reduce the incidence of the composite outcome of death or BPD or its components. So let's look at the study design. Follow-up of an RCT. We know that RCTs, although they are somewhat flawed because babies do not fit a or B sort of thing and every baby is different, RCTs are the gold standard of medical research. They had clearly defined stratification for their study. And again, follow-up is really important. So this is good. Blinding of clinicians and outcome assessments. Again, this is a really important aspect of research. The gold standard would be double-blind, placebo. Again, that's very, very difficult to do, especially when you're doing something that involves a procedure or not. And I thought it went really well from the couple that I did participate in, just from my anecdotal experience. The blinding was able to be sort of carried out to a point. We did, at the hospital I worked at, we stood behind a curtain and we basically talked through MIST, and sometimes the patient would receive MIST and sometimes we'd just sort of shuffle them in the bed and pretend we were doing it. And some people, there is an element that, of course, that's not perfect because, you know, maybe 3 weeks later that consultant rotated onto duty or that nurse cared for that baby and they had known. But I think that this was a really good sort of intermediary way of attempting blinding and something that is very, very difficult. However, for the follow-up trial, the outcome assessors were blinded to the original trial allocation group, which is fantastic. So the people who were doing the assessments and sort of looking at the data did not know which original group these babies were in. The sample size, so as Dr. Dargaville did say, they did have less infants included in the final trial than what they ideally wanted. However, they still had a really good number, and I've got my baseline 6% follow-up, but as Dr. Dargaville said, it was actually a lot higher, which is really, really fantastic, like I said. And the statistical analysis, they used relative risk, comparing active treatment with control with 95% confidence intervals were estimated according to randomization group using a generalized linear model. And the generalized linear model used the modified Poisson approach of zoo with a log-length function. So that's very wordy and very, very statistical. So basically, and I'm wondering maybe either of the investigators could sort of chip in, but the way I sort of approach it with these sorts of RCTs are that relative risks are nice because they're kind of more intuitive than odds ratios, and they're more sort of useful for applications such as clinical sort of outcomes. And the Poisson regression, it's used for count data and monitoring. It's a really common, like for hospital visits, number of times visiting somewhere in the last month or whatever. And the modified Poisson regression looks at binary outcomes. So this is a really appropriate statistical method to be used in sort of a trial. Of course, this trial would have had study statisticians, as we all do, but I don't know if any of Dr. Dargaville, you'd like to comment on any of the study design and methods. I think it's a really well-designed trial. I think you can talk about how you approach maybe blinding, because it is so difficult, especially when it's such a procedure. And for some of these instances, like you alluded to, the clinicians were actually taught the missed procedure at a lot of places. So for this was a new procedure for the nurses assisting, the doctors performing the treatments, or the nurse practitioners or whatever. So how did you sort of think about blinding and approach that?
Well,
did you have any pushback?
Yes, and many units decided they couldn't join the study because of the need to have a treatment team, and because of the imposition of this blinding into the trial design. But yet one would have to say now in retrospect, having done it, is one of the very big strengths of the study. And not only did we do blinding, we also measured it by giving 3 members of staff a survey once the procedure had finished, and asked them whether which group they thought the baby was in. And we wrote a paper about the success of blinding. Lizzie Reed, our trial coordinator, was the first author of that. It's in Clinical Trials from a year or so ago. And what we found is that in about a third of the time, the clinicians guessed correctly which allocation group the baby was in. In about 11% of cases, they actually guessed the wrong group, and in about 50% of cases, they weren't sure. And we used different metrics of blinding to know whether we'd been successful, and found using one called the James Index that we were successful in achieving the blind. And that now becomes as I said, one of the strengths of the study. Only one other of the clinical trials that has looked at thin catheter surfactant delivery has been blinded.
Yeah, fantastic. And again, like I did say, that with this follow-up trial, the outcome assessors were truly blinded to the original group of participants, which is great.
Well, yes, and that's true. And maybe you're going to say it, but in most cases, those assessors were parents.
Yes, I'm going to talk about that.
Yeah, good.
Sorry, yes. Yeah. And maybe that is a good sort of time to talk about actually the parent involvement in the follow-up aspect. Oh, no, actually, I'll come to it later. Sorry. Okay, so now we're moving on to outcomes. So our neurodevelopmental disability or death at 2 years of corrected age. So I didn't want to sort of bombard everyone with lots and lots of numbers. So I just thought we'd remind ourselves that in Optimist-A, there was the one sort of significant outcome. Oh, I've forgotten the decimal point, sorry. When BPD in survivors at 36 weeks, that was our significant outcome in the first trial. So what were some of their outcomes in the follow-up? We had the composite of death or moderate to severe neurodisability by 2 years of corrected age, death or so the individual outcomes, death or neurodevelopmental disability by 2 years corrected age, at least another outcome, at least one aspect, and 3 or more hospitalizations in the first 2 years, measures of respiratory morbidity in the first 2 years, and frequency of tube feeding beyond 1 year corrected age. So composite of death or moderate to severe neurodevelopmental disability by 2 years corrected age. This is a really sort of, just from reading it, it might seem kind of, well, death is objective, but the moderate to severe neurodevelopmental disability could be quite subjective. So how did the team define that? They had several important markers. So cognitive or language impairments. These are the standard developmental tests that are used all over the world. So we've got Bailey's, and then they used a parent report assessment, which is really fantastic. And I think that if we look at things like general movements or child development, that parents are often really important to acknowledge in the sort of diagnostic trajectory of these babies, because they're there with the babies every single day and they will know their child very well. And I think that the Optimist team involving the parents really sort of, they really sort of used and optimized their chance of getting good follow-up data by involving and doing a parent report assessment. So the parents also reported on the cognition and language development of their child. They also looked at cerebral palsy, so gross motor function scores. The parent reports walking with help, doesn't walk with help. They looked at visual impairment, so sees close-up objects at best, even with glasses, and asked the parents how they are doing. And hearing impairment. So these are all really standard and really important. And I wonder, Dr. Dargaville, did you have any sort of hesitation from parents to do this? Were parents, do you think, or from your research team, were the parents excited to be part of it? Were they excited to do the parent report assessments and the abbreviated questionnaires? Was there any hesitation from parents?
Just to clarify, Anna, so we started out with the idea that we could get face-to-face follow-up in all the participants of the trial. That was what we were aiming for. That would still be considered the gold standard. But for a whole lot of reasons, and in particular because of the multiple sites in many countries that got involved, we did opt for an online questionnaire. It's a validated one called the Parker-A Parent Report of Child's Abilities. And Samantha Johnson, who's the creator of that questionnaire, was an investigator on our follow-up study. And that's sometimes administered in a face-to-face form, but the beauty of it is that it can be administered in an online format. And our parents signed up for face-to-face follow-up at the beginning of the study, so they knew that their child was going to be followed up at 2. But the method of the follow-up ended up being different in most places, and ended up being an online questionnaire. And that was a link to that questionnaire was sent by the site investigator at each site. So we back at home base didn't have any direct contact with the parents because we hadn't asked them to sign up for that. And so the site investigator sent the link so that the parents could complete the questionnaire. And sometimes it took a few reminders, as Dr. Ram has said. Sometimes they did need to be reminded a few times, and there were instances, as we saw, where they didn't actually ever complete the questionnaire. But we did get lots of favourable comments because we asked at the end of the questionnaire whether the parents wanted to say anything, and they gave us often rather moving tributes about how their child was doing, but about how they appreciated the opportunity to be involved in the follow-up study. There were such messages that came through for us, and it ended up in COVID times being a very effective way of getting follow-up data when there would not have been face-to-face follow-up available.
Definitely. Thank you for that. So what results did they find? So it's always important when interpreting journal articles and research to look at the base demographics, because you want to know that the babies or patients in each group were the same. Because if you have sort of extreme, all 22 weekers in your intervention group and all the 28 weekers in your control group, well, then you're going to have some sort of confounding variables there. And a good randomization should take care of this for you. But it's always important to really closely check your demographics and things like that to know that you are sort of getting the same babies in each group. And that's what they did have here, which is, oops, I've gone backwards, which is fantastic and really reassuring. So there were some data gathered at first hospital discharge. Again, just making sure that the groups are sort of well matched in the things that they could be. And obviously oxygen therapy at home might differ a little bit because of the nature of the intervention. But as you can see, things like immunization, family history of asthma, or corrected age, they were all sort of really well matched. And the babies were getting assessed, or these assessments were being provided at a similar sort of age in both groups, which is really important. You can't be comparing 3-year-olds with 2-year-olds for a 2-year developmental outcome. So here are all the neurodevelopmental outcomes of interest that the team looked at. We had death on neurodisability composite, death prior to 2 years, neurodevelopmental disability by itself, cognitive or language impairment, language impairment, cerebral palsy, visual impairment, and hearing impairment. And we're looking at, I just decided to show the risk difference because I've found that clinicians quite like looking at it more than odds ratios, like I said. And then I know that we're sort of veering away from the p-value, and it's a bit of a contentious topic to p-value or to not p-value. So I've just left it with risk differences. And the way you sort of interpret that is if it crosses 0, it's probably not significant. So interestingly, there was a significant variable here in visual impairment. And I wonder if the authors could sort of hypothesize why they think this is, if they think it's just one of those things that happens, or if they were expecting to see sort of, if they were surprised by any of these neurodevelopmental outcomes and what they found, or if anyone wants to comment.
Well, I would certainly make a couple of comments. The first is that, of course, when one designs the follow-up component of a study, one has to choose an outcome of most interest. And if you ask parents, and certainly ask clinicians, they'll go for neurodevelopmental ability or disability in this case as the outcome of most interest. And there were data to suggest that babies who had a lesser risk of BPD or a lesser incidence of BPD might then go on to have a lesser incidence of neurodevelopmental disability. There are some studies that have certainly linked those two, and yet there are others that don't quite link them in the way that you'd imagine. So that was the reason why we wanted that as our primary. But the other part of the equation is we were in the babies in the active treatment group doing a procedure that involved laryngoscopy on every single one of them in the first day of life. And in the control group, not all the babies actually got a procedure because some of them never needed surfactant. And so there was the concern that might be raised in the active treatment group, actually, that there could be an effect from having a laryngoscopy on the first day of life, which we know in some of them caused hypoxia and or bradycardia. And so it was important for that reason to examine the safety of that active intervention as well at 2 years. As to the effect of visual impairment, we didn't make too much of that. The trial was in no way powered to be able to really look at that outcome, and that difference there doesn't really fulfil a pre-specified hypothesis in any way. One could say perhaps that if babies were on ventilators for less time, which they were in the active treatment group, that they were perhaps exposed to less oxygen, but we have no way of measuring that.
Thank you. And I will just reiterate that it's really important because the babies in the missed group, some of them did get double treatment because some of them were intubated after their miss, and whereas in the standard care group, they only, if they went on to get intubated, that was only sort of one sort of thing. And again, with these clinical trials and RCTs, it is funny that I think Professor Peter Davis once told me that, if you throw a bunch of stuff at a wall, something's going to stick. And you do sometimes see significant things like this that you sort of, you're maybe very, very underpowered to look at, or It's just sort of a finding, and you may have some hypothesis as to it, or it might be something for a future direction. And then we move on to sort of like hospitalizations and respiratory health in the first 2 years. And this is interesting because there's a lot to talk about in this. And even though the primary outcome was death or neurodevelopmental disability, respiratory health is really important because surfactant is a respiratory drug, and this was a procedural trial, yes, but it was also a respiratory trial. So they looked at hospitalizations with any illness, hospitalizations with respiratory illness, parent-reported wheeze or difficulty breathing, any sort of bronchodilator therapy, and any parent report of a physician diagnosis of asthma. And if you started to look at any of the risk differences here, you will see that there are some significant outcomes here. Ooh, where's it clicking? There we go. Ooh, there we go. And if we look at hospitalization, there's like sort of 1 or sort of 3, and both of these outcomes were significant. So babies in the MIS group were significantly different to babies in the control group, sorry. We look at hospitalizations with respiratory illness again. With the first one, with 3, greater than or equal to 3, we didn't see a significant difference, but with greater than or equal to 1, we did. And in the parent report of wheeze, bronchodilator, or asthma diagnosis, you can see that there was a significant difference between the 2 groups. And to me, some of these findings are not surprising because babies who receive surfactant, we know now, Dr. Dargaville said that throughout the sort of process of Optimist, there was so much surfactant research being done. And there were, we overwhelmingly now give surfactant, and we know that it benefits babies and their respiratory health. So I think these secondary outcomes are really reassuring. And again, if we just look at them, I did chuck some p-values in here just in case anyone really likes p-values, but you can see here that they are all quite significant. And this is really reassuring and really, really important aspect of the follow-up of this study. And I wonder, Dr. Dargaville, if you wanted to comment on any of the sort of respiratory outcomes, or I wonder if you were surprised or not surprised, or if you have any comment about this. But
well, thanks, Anna. Look, we had wondered, but it should be said first up that the link between surfactants and chronic respiratory morbidity isn't as clear-cut as you might imagine, and that of all the placebo-controlled trials that were done in the old days, not many of them actually showed an effect of surfactant on BPD, and there might be reasons for that. They showed an effect on mortality and on pneumothorax. And so we weren't necessarily sure that we were going to have, that there could be a lasting effect of a day 1 intervention, a single day 1 intervention. Could there be a lasting effect on respiratory health at 2 years? Obviously, we had the data from the BPD analysis to suggest there was an effect, albeit a relatively small effect, 8% absolute risk reduction in BPD. So we clearly were very interested to know what the respiratory health for these children was like in the first 2 years, but I wasn't necessarily expecting the results to be so clear-cut, I have to say. And if you ask parents beyond the neurodevelopmental disability domain, that of course is the top of any parent's list in relation to outcomes they are wishing to avoid in their child, the next most important set on the list is that they'd like their child to not be going to hospital and not be suffering respiratory disease. And so this is why this was a very important metric for us, and to have seen a 1/3 reduction in hospitalizations with respiratory illness was a very important result and a very rewarding result from the study.
Dr. Ramanathan,
Yeah.
US has,
Yeah, this
go
is
ahead.
very similar to the trial we did 15, 20 years ago with Jonathan Davis. For sicker babies, they got recombinant superoxide dismutase to decrease lung injury or BPD. We actually didn't see a decrease in BPD. However, the respiratory outcomes in the first 6 months a year, babies needing hospitalizations, bronchodilator use, they were all significantly less. So, the respiratory health was better. However, the definition of BPD was not improved. Very.
Yeah. So, Dr. Ramanathan, you bring a good point about this composite outcomes and what outcomes actually matter to parents. US has lagged pretty behind adopting the LISA and the MIST for it. Do you think this is a really good data points? Even though composite outcome was not significant, the outcome which actually matters were pretty significant and strongly moving in the right direction. Is this enough to bring a culture change?
I think the Cochrane review, if you look at it, clearly showed the death or BPD as a composite outcome, number of babies requiring mechanical ventilation or intubation was 72 hours, or BPD alone number needed to treat is like 9 babies. So with LISA, that was comparing LISA versus Insure, not LISA versus or MIST versus no surfactant, no C or just CPAP, right? So I think the people are giving surfactant, sure. Most of them are doing Insure. And the major reason people are hesitant to use MIST is that the fear that the babies will fail non-invasive support. I think clearly in babies around 23, 24 weeks, it may not work well, but about 25 weeks and above, if you're going to give surfactant, it's probably based on the data and meta-analysis, Cochrane review, LISA or MIST is probably the best way to go. I think people are slowly getting convinced to try this approach in the US.
So while Anna wraps up final slides, I'm going to launch a poll to see if our audience thinks about what their practice is. Anna, you can wrap up your final few slides quickly.
Yeah, I did have one of these polls. It is funny that it is becoming adopted here. I know that when I was running my trial, our unit moved to sort of like routine practice, first line surfactant administration in the older, extremely preterm, more mature, extremely preterm babies. And we very rarely are intubating the 26, 27, 28 weekers now, and it's really our routine practice. So after those results, we go back to our hypothesis, and the hypothesis was that the application of MIST would reduce the incidence of the composite outcome of death or moderate to severe neurodevelopmental disability or components from the original sort of hypothesis that MIST would reduce the composite of death or BPD and its components. And the investigators did not find that the surfactant or MIST LISA had a significant reduction in the incidence of death or neurodevelopmental disability or its components at 2 years of age. But like we've just seen, they had some really important reductions in some really important respiratory health markers, such as number of hospitalizations with or without a respiratory diagnosis, and asthma, parental reported physician diagnosis of asthma, use of bronchodilators, and like Dr. Dargaville said, you do talk to parents, and after death and disability, things that they do say is not frequent hospitalizations. We get a lot of, is my baby going to have asthma? And it's really important to have this data to not only share with international colleagues to sort of spread the word of MIST, but to be able to reassure parents as well. I did want to talk, I'm aware like that I might be going over time, so I'll just go really quickly through some strengths and limitations, and then we might ask where have my strengths gone? Sorry. We might ask the investigator, Dr. Dargaville, what he thinks his main strengths and limitations were throughout this. But some limitations were a follow-up of a study of a clinical trial that was not specifically designed to detect differences in 2-year outcomes. The main clinical trial was death of BPD. The analysis of the follow-up data involved multiple additional comparisons beyond those previously reported. Sample size was limited, as we talked about the early closure of recruitment due to the COVID-19 pandemic, with the sort of lack of face-to-face assessment. But I think that Dr. Dargaville did really nicely explain that the support for the parental report seemed to be a good substitute for a face-to-face assessment, and several methods of data capture were used, including online questionnaire and parent report, which we know there may be, it may not be as accurate as face-to-face, but I still think that they did really, really, really good job. It's one of the largest studies, as they said, to this date to explore this. They got some really still a large sample, and I really think that this study should be commended. And just going on really quickly, food for thought. The lower incidence of BPD at 36 weeks in Optimist-A was noted in the MIST group did not confer to a reduction of neurodevelopmental disability at 2 years, although BPD is a known risk factor for neurodevelopmental disease and disability in childhood and adolescence. And I think, Dr. Dargaville, you sort of alluded to this, that, you know, there is some school of thought that BPD, it can be a risk factor. And so I just wanted to have these in as food for thought. And like we said, exploratory subgroup analysis for the outcome of death prior to 2 years corrected age, there was some evidence of an interaction suggesting a higher mortality risk in the 25 to 26 week gestation stratum associated with the allocation to the MIST group. And Dr. Dargaville, I wonder, sorry, I'm really conscious of the time, and did you want to comment on any strengths, weaknesses, any of your sort of take-home messages, food for thought, what if this has been sort of hypothesis generating for you in any way moving forward? I know that Tassie is absolutely misting babies, so it's obviously been adopted in your unit.
Yeah, it certainly has, Anna. I'll just comment on a couple of strengths that should be mentioned, and that is that this was a international multi-centre study done in a whole lot of units at various levels of sophistication around our world, and included centres in North America, in the US and Canada, but also centres in the UK and Europe, centres in Turkey and Israel, and then centres in Australia, New Zealand, Singapore. So it was very much an international effort, but it also means the results are reasonably generalisable, one would think. The second important strength is the blinding. That certainly adds a layer of validity that most of the other trials looking at thin catheter surfactant delivery have not had. In other words, the clinicians know whether the baby did or did not get treatment a certain way, and that inevitably will affect their behaviour. Now, of course, some of the clinicians in this study did guess right, but they didn't know for certain. They didn't know for certain, and that's an important point of difference. And as I think you've clearly enunciated the limitations there, including the fact that we didn't reach our target sample size. That's an important thing. You also mentioned the subgroup analysis in relation to outcomes, including mortality. And there one has to be clear in understanding that subgroup analyses are not powered usually to look at outcomes that have a low incidence like mortality. But yet we did see a significant p-value for the interaction term. And that means in the statistical analysis that when we're looking at gestation strata, that being allocated to the LISA group or the MIST group in the 25 to 26 week strata was associated with a higher risk for mortality, and in the 27 to 28 week group, it was associated with a lower risk. But to be clear, there was no head-to-head difference when you looked at those strata head-to-head. it was a p-value for the interaction term. And this is how these things are usually expressed. And that would be one of the hypotheses that could be generated. You know, is it safe in terms of mortality to perform MIST in the babies at a lower gestation range? Well, we did a lot of analysis to try and work out whether we could find deaths that were clearly related to MIST in the small babies or in all the babies, and we really didn't see deaths that we thought could be directly ascribed to it. So I don't know that we're going to be able to get to really say too much more about that, and that'll be something that clinicians will eventually come to understand, is how to do MIST safely. But you wouldn't expect that association of MIST and death is going to be turn out to be something that's real and concrete.
Yep.
And other studies not found that. I'd obviously be interested in the comments of others on that.
So, Dr. Ramanathan, a question for you. From the poll, we saw only 50% of our trainees are trained on giving MIST, and about 50% still think it's only safer to give, or in their opinion, effective and safer to give for more than 27 weeks. So should we train our fellows up to, this should be a part of our ACGME requirement, given the strong results we have seen from the trial?
Yeah, I mean, when we train them, we typically use the, Leerdal 600-gram baby, right? Mannequin. So that's pretty much what we teach them, I don't think when we are teaching intubation and or in LISA technique, that we need to say we are not going to use it in babies below certain age. Depends on each baby, right? The baby comes out, good respiratory effort, not a general anesthesia, C-section effect is not there, mom has not been on any drugs, may have a very good respiratory effort. We support them with NIPPV in these micro preemies. So we have much better results in minimizing the need for intubation. We have published a few studies on that. So if CPAP is not working, and people are using other non-invasive modes to support the baby, nasal oscillation, nasal jet ventilation, everything that we can do to avoid intubation safely. So if you do that, and you get to see some 24-weekers are staying on CPAP. So post-surfactant, I think those babies, you can use LISA easily.
And do you think it should be, the LISA training should be part of the ACGME fellowship requirements?
I think so. I mean, not only, if you ask me, we do a lot of functional echocardiogram training. Focus in general, neonatologists have not adapted it in the US, right? You go to ED, they do. You go to OB, they all do ultrasound, right? Except neonatal fellows and neonatologists are not. We are behind.
So I have a question from the audience. So what do you think about growing interest in SALSA, which is surfactant via laryngeal mask? What do you think make providers in the US to introduce SALSA primarily more than MIST? Dr. Ramanathan, you want to comment first, and then we can move to Dr.
Yeah, I put in a chat, SALSA is feasible at the present time in babies about 1 kilo. Carrie Roberts, who has done a lot of work, she actually has a small-sized LMA. She has a patent on it. It has not been released. We use AirQ 0 and 0.5 in some babies. We teach our fellows. We also used in some babies less than 1,000 grams. Clearly, majority of the babies that require surfactant that you want to do are going to be less than 750 grams or 800 grams. So we really don't have a good small size LMA. I think AirQ 0 or 0.5 is probably the best so far. Yeah.
Anna, you had a point to make?
I was just going to say, watch this space, because there's a large RCT going on at the moment down under that's looking exactly at this, and looking at it's called the Surf's Up trial. If anyone wants to have a squiz at it, it's been registered, and it's recruiting, and it's looking at LMA surfactant administration in late preterm and term infants. And I'm very excited to see the results for that, especially in sort of like level 2 units where, you're clinician might not be skilled in mist, and this is a really safe, well, it might be a really safe alternative. So I'm excited, and just, yeah, watch this space, because people are looking into it.
That's great. So we're almost on a time. Dr. Dargaville, do you want to give a final closing comments on the study and in general some advice to all the trainees who want to do some more mist when they go back to the units?
Well, I think the Optimist trial overall, including the 2-year follow-up outcomes, showed that LISA mist appears to be safe and certainly appears to have an effect on respiratory health in the first 2 years, and therefore can be recommended compared with continuation of CPAP. That's what our comparator group was. Similarly, the Cochrane analysis of 14 studies comparing LISA mist with surfactant via an ETT also showed a benefit of the LISA mist approach. So I think there's now a pretty large body of evidence, well over 1,000 babies in trials, that suggests that we should be looking at this approach of delivering surfactant via a thin catheter. And just to emphasise that the difference between giving it this way is that we're using or harnessing the baby's spontaneous breathing in delivering and dispersing the surfactant from the trachea. And that we now know to be the unexpected windfall of this approach, that it seems to be more effective than delivering surfactant into the trachea with an endotracheal tube and using positive pressure to disperse the surfactant. So that's an important part of the technique, and it's hard to replicate that with salsa because for administration of surfactant via an LMA, most people would have to use PPV to disperse the surfactant into the lung. So I feel like there's enough of a body of evidence to use the technique, and I would urge trainees to learn it and to refine their laryngoscopy technique to allow them to use it on a spontaneously breathing baby who's not been muscle relaxed, and to gain the benefit of that.
Yep. I think there's one final question from the audience. Dr. Ramanathan, I'll direct to you. Do you recommend using any sedation or analgesia during LISA?
Another controversial topic, but we use atropine and sucrose. If the sucrose is not able to hold it, then we use fentanyl in bigger babies, but in most small babies we use atropine and sucrose.
Dr. Dargaville, as far as I remember, you don't use much, but do you have any comments on the analgesia part?
Yeah, well, we're certainly using non-pharmacological measures for comfort, for tolerability of the procedure, and that does include, in our case, swaddling and sucrose. Atropine hasn't been used a lot in our unit. It wasn't used much in the Optimist trial, and the Optimist trial in the 25 to 28 week range did not allow sedating pre-medication. I would admit in babies that are more mature, there may need to be something given to help the tolerability of the procedure, but the last thing we want to do is sedate babies prior to having surfactant delivered via a thin catheter. If we can afford them some form of analgesia without a sedative effect, that would be great. And that's something that has to be considered, particularly for the babies at more mature gestations.
Cool. Thank you. Dr. Ramanathan, do you have any final comments?
No, there's a question about caffeine pre-mist. There are centers like in Vienna and other places that do. They actually give caffeine in the delivery room and then you're going to mist. In our unit, we do caffeine pre-LISA.
Yeah, sounds good. Well, with that, I would like to close the session. I would like to thank Anna again. There was a splendid presentation, and we are very grateful to have the insight from Dr. Ramanathan and Dr. Dargaville. We got to learn a lot today as such. We do have our next session next month on March 14th on the kangaroo mother care trial. We'll be joined by Dr. Nellis from Sweden and Dr. Wally Carlo from USA. So we look forward to see you again there. And thank you again, the mentors, for coming. And thank you again, Anna, for that excellent presentation. Hope to see you all again soon.
Okay, thanks for the invitation.
Thank you.
Thanks.